I like to welcome Dr. V.S. Hariharan and Dr. C. Sendil to chair the session.
Good afternoon. So, welcome to the afternoon session of DAISICON2025. I know it's a very difficult session post-lunch, but then to have it interesting, we have three great speakers today. And to start the session, we will have Dr. C.S. Gauthaman sir, who will be speaking on challenges and solutions in hypertension management in diabetes. I think diabetes as such is being spoken over, and hypertension accelerates the complication, end-organ damage that happens. So let us learn from Gauthaman sir about how to handle the hypertension in diabetes.
Good afternoon and all. Welcome to the post-lunch session. I'll try to keep it simple. First, my wishes and respect to all my seniors and my colleagues, and thank the organizing team to giving me this opportunity. My topic is challenges and solutions in hypertension management in diabetes, and these are my agenda. So I'll be talking about the double burden initially, then I'll talk about the crosstalk between hypertension and diabetes, and also I'll talk on the under-recognized pitfalls in diabetic hypertension, and I'll end up with the right therapeutic. Diabetic hypertension, as you all know, it frequently coexists, and which amplifies the cardiovascular and renal risk. It not only coexists, there is a synergistic damage to the endothelial dysfunction, atherosclerosis, nephropathy, as well as heart failure. Why it matters? Recognition of this double burden early is critical because an aggressive BP control can bring down the cardiovascular events as well as the glucose control. The prevalence data is around 60 to 80% of type 2 diabetes will have hypertension globally, and also around 50% of uncontrolled and long-standing hypertension are having high risk of developing diabetes, and only 30% achieve the BP target of 130/80. And a cross-sectional analysis of this double burden of sex-specific prevalence has found out the hotspots in mainly Tamil Nadu, Kerala, Andhra Pradesh, Telangana, Karnataka, whereas the northern and northeastern states have a lower prevalence because of a lot of other factors we'll be discussing later. And this synergistic amplifies the damage and is a leading cause for the CKD and ESRD, and also the proteinuria progression is aggravated. There's a risk of retinopathy is multiplied, and there is a higher risk of CAD, LVH, as well as chronic heart failure. And sudden cardiac events are very common when this both coexist. The risk of stroke is also doubled. The peripheral artery disease and the critical ischemia risk is also magnified. The crosstalk between diabetes and hypertension, it's like hypertension causes insulin resistance, whereas insulin resistance once again increases the hypertension. The common pathophysiological amplifiers are insulin resistance and hyperinsulinemia, obesity, ROS overactivation, sympathetic activation, inflammation and oxidative stress, and sodium retention. Insulin resistance and hyperinsulinemia, they are central to both the conditions, which leads to sodium retention, sympathetic nervous system activation, and vascular smooth muscle proliferation, which leads to elevated BP. They also cause damage to the endothelium, which brings down the nitric oxide bioavailability, leads to vasoconstriction, stiffness, and once again they produce a prothrombotic state. They also produce a low-grade chronic inflammation with the elevated CRP, IL-6, and TNF-alpha, which leads to vascular remodeling and microvascular damage. The overactivation of the sympathetic nervous system will cause increased adrenergic tone, increase in BP, insulin resistance, and also there is a higher risk for arrhythmias. RAS and angiotensin II. Angiotensin II causes renal vasoconstriction, proteinuria, glomerular injury, proteinuria, also promotes oxidative stress, fibrosis, and endothelial dysfunction. So ROS is a central link between these two diseases, hypertension, diabetes, as well as CKD. The GLP-1 receptors in the carotid body, they play an important role, as we have now started using more of GLP-1 receptor agonist. It causes sympathetic modulation, that is, it reduces the excessive sympathetic drive. Also, there is a metabolic function modification which helps in improving the sensitivity to glucose fluctuations. It also improves the vascular effects, improves the endothelial function, and also reduces the oxidative stress. These are the clinical trials. The leader, Sustain 6, Rewind, and Amplitude O-Trial, all of them cumulatively have brought down, I've mentioned that it brings down the MACE incidence, as well as it brings down the systolic BP around 2 to 4 mm of mercury. Very important in diabetes is the hidden hypertension. Number one is the masked hypertension, that is the office BP is normal, whereas the out of office BP is more. And nocturnal or non-dipping hypertension, now that is the normal 10% dipping is not observed in these people. And the masked uncontrolled hypertension, whereas the treated people with a normal office BP and out of the office BP is very high. These conditions are very common in diabetes, and they are the leading cause for the microvascular and macrovascular injuries. And the microvascular, most commonly nephropathy. Nephropathy is caused by nocturnal hypertension, non-dipping hypertension, and the nighttime high systolic BP is more prone for retinopathy, and the risk of stroke is also magnified by nocturnal hypertension. And what do the current guidelines say? The ADA standards of care advises to do home BP monitoring and as well as 24-hour ABPM to detect white coat hypertension, masked hypertension. And our Indian guideline RSDS recommends ABPM plus office and home BP monitoring. Whereas the public health program, where the ABPM and home BP monitoring is not feasible, they advise to do 2 office visits, which can be widely used in the public program. And when to do ABPM? When the systolic BP is around 130 to 139 and the diastolic BP is around 80 to 99, as well as we observe a controlled BP, but there is the presence of albuminuria, retinopathy and LVH. Whenever there is a symptoms of OSA, as well as when we observe multiple variable readings, we have to advise the patient to go for ABPM and home BP monitoring. And how to measure it right? We should have a validated device, an appropriate cuff, and the patient should be seated 5 minutes before measuring the BP. And home BP monitoring, it should be a repeat and average. We have to do at least 2 times in the morning and 2 times in the evening for 1 week, that is 2 into 2 into 7. Okay. And ABPM is mainly used for night BP and dipping and also to measure the morning surge. I'm going to talk on the some under-recognized risk amplifiers. The number one is the high sodium intake as well as salt sensitivity in diabetes. Most of the salt, around 80% of the salt, come from processed and restaurant foods. So whenever the patient says I'm taking only less salt, they mean only the home salt what they take. But this is the hidden salt which is seen in the bread, snacks, sauces, pickles, cheese, instant noodles, breakfast cereals and fast food. These are the salts which is causes the salt insensitivity and high sodium intake. So always advise them to avoid processed food. This kind of food are mostly avoided in the northern and northeastern, in most probably northern eastern states. That's why the incidence of hypertension is very less in northeastern states. And next under-recognized pitfall is the prolonged sedentary time. Sitting for quite longer time will increase your BP. Even a modest slight reduction can improve the BP, especially the systolic BP. So we have to make a sit-stand movement plan in the care plans. The next is the obstructive sleep apnea. So whenever you see a patient with rest and hypertension, think about obstructive sleep apnea. If there is a history of snoring or daytime sleepiness, always screen for obstructive sleep apnea. Treating obstructive sleep apnea or using a CPAP will definitely bring down the systolic BP. The most important is the polypharmacy. Polypharmacy is very critical in both diabetes and hypertension. The very common drugs which can cause rise in BP are the NSAIDs, oral decongestion sympathomimetics, certain antidepressants, SNRIs and TCAs, corticosteroids and calcineurin inhibitors like tacrolimus, cyclosporins, all these things. They have documented pressure effects mediated through renal sodium retention, sympathetic activation and endothelial dysfunction. Whereas these diabetic patients already they have a history of volume expansion, autonomic imbalance. With the ordered pressure effects, the effect of the AC inhibitors and ARBs and other hypertensives are blunted. So always have a review of the polypharmacy of the patient. Last is the orthostatic hypertension, autonomic neuropathy, which is common in diabetes, may prompt the physician to under-titrate the dose. So always we have to check the standing BP. Orthostatic hypertension in diabetes elevates mortal risk by 100% and predicts greater cardiovascular heart failure events. So always check the upright BP in clinical care. Coming to the right therapeutic thing, the Indian Hypertension Control Initiative have standardized the use of amlodipine, and to add on to it, you can use telmisartan and chlorthalidone. Why? I'll tell you now. So they are advised to start on amlodipine, and they made it as a triple drug therapy. The add-on therapies of telmisartan is because it is long-acting, good evidence in diabetes and metabolic syndrome. Chlorthalidone chosen over hydrochlorothiazide because of better cardiovascular protection. The step curve model has ensured simplicity, uniformity and scalability in most of the primary care settings. Apart from the stepwise approach, what we need to is a lifestyle modification. The sodium should be less than 2.3 gram per day, that is dash sodium, that is 5 gram of salt, and we should advise the regular walking, that is standard 150 minutes per week, screen for OSA, review the medications and avoid high calorie foods, saturated fat, alcohol and quit smoking. Always increase fruits and vegetables, whole grains and potassium. During the therapy, you have to monitor potassium and creatinine if you are using ACE inhibitors and ARB, as well as MRAs, and always monitor the electrolytes when your patient is on thiazides. And whenever you titrate a molecule, always recheck the ABPM as well as home BP monitoring. And the adjunct therapies, many of my previous speakers today morning, they were talking about the SGLT2 inhibitors, GLP-1 receptor agonists and fenrinone. All these drugs will be very useful in diabetes in treating the hypertension. This is an important slide where the meta-analysis of multiple studies have mentioned that single pill combinations versus a free equivalent combination. The single pill combinations, as mentioned, it has got a better medication adherence, medication persistence, better SBP reductions, better diastolic BP reductions, and also achieving the target the patient is very good. So what combination works best according to the accomplished trial? The benazepril amlodipine, that is ROS blockade with CCB, is superior to benazepril plus hydrochlorothiazide. This supports the high value base in patients, and this extrapolates what we use regularly. We have used more of telmisartan and amlodipine single pill combination in India. Also, chlorthalidone or indapamide is preferred over hydrochlorothiazide for a stronger 24-hour BP control. As per the advanced trial, the perindropyl indapamide has given a very good evidence of major vascular events and all-cause death in the type 2 DM. Chlorthalidone with hydrochloroside, the CV risk in thiazide-like diuretics like chlorthalidone has got a 22% risk reduction. The risk of heart failure is 43% reduced in chlorthalidone, as well as 18% risk reduction is observed for stroke. So why it is a smart pair, telmisartan and chlorthalidone? It's a once a day, long off-life telmisartan along with a potent outcome-proven chlorthalidone, which is a strong 24-hour overnight BP coverage. The on-target and detailed trials have given evidence of this better cardiovascular protection of telmisartan. So synergistic effect on both the drugs will regress LVH, albuminuria, CV event reduction, and also aligning with the end organ protection goals. So this direct Indian clinical study proves that telmisartan and chlorthalidone combo has mean BP reduction of 4 to 5 mm mercury and mean diastolic BP of 4 to 5 mm mercury, and that it is well tolerated without any major electrolyte imbalance. So even the moderate reduction in the BP has got a meaningful CV risk reduction. So this combination always proves better. So this is the why it has got an added edge. Superior BP control, better 24 hours and night BP coverage, clinically proven combo, and its metabolic friendliness. Stroke and CV risk reduction is very high in this Indian population. So how to build the regimen? Start telmisartan, add chlorthalidone or amlodipine as a second agent, consider single pill combination for adherence. And if there is a high CV risk, start on RAS blockade with a CCB and then add chlorothalidone. Whenever you observe a resistant pattern on nocturnal BP, you can favor chlorothalidone as a diuretic, but you can also add spironolactone, which is indicated in the pathway 2 trial. What are the future in hypertension management? Zilebesiran, which is a subcutaneously injected RNA interference targeting angiotensinogen. Baxdrostat, which is an aldosterone synthase inhibitors. And aporacentan, which is a dual endothelin A and B receptor antagonist. Also, renal denervation, they are in future cuts. It's better we develop a single pill combination with anti-hypertensive agents, glucose lowering agent, and anti-lipidemic agent to improve compliance. So, managing hypertension diabetes is not just about reaching the numbers, it is protecting the vital organs. The challenges are real, but the solution is equally clear. Measure right, treat out of the office burden PP, optimize lifestyle, and prioritize RAS blockade, and always choose the evidence-based combination like temnosartan with chlorothalidone to combat diabetic hypertension. Thank you for the patient listening.
Thank you so much, sir. We'll take the questions towards the end of the session.
So good afternoon. It's my privilege to introduce the next speaker, Dr. J.S. Kumar, who is going to give a lecture on the clinical value of biosimilar interchangeables. It is a new topic for all. Let us listen to this.
J.S. Kumar sir is the head of the Department of Medicine in SRM Medical College, also Dean for students, postgraduates over there.
Good afternoon. I know that this is a post-lunch session and this is a topic which is probably not discussed too much in clinical scenarios. So bear with me for the next 12-13 minutes as I'll rush through the hard science between why these biosimilars are being discussed in this kind of scenarios and in forums, so that you can have a good idea. So when so much of biosimilars are available in the market, is it right to choose? If it is okay to choose, what about if the cost is also not a constraint? How am I going to give what would be my prescription change or my pattern? So let's look at this particular analogy. I think we all have, since childhood, have traveled in trains. So we had the old air-conditioned trains, as well as then came the Rajdhani, and now of course we have Vande Bharat with night sleeping facility. So if you are looking at it, even though they look outside a bit different, but it does not give the same experience. If you look at the old trains, which now I take it as a biosimilars, they may look similar outside, but they are inconsistent with comfort and hygiene. But if it's an innovator like Rajdhani Express, I think it's known for its comfort as well as punctuality. Then now we have all experienced Vande Bharat. I think nothing great to talk about because we all experience, and it's a wonderful experience for all of us. So it is equally reliable and it is faster. So that is almost that if you are going to travel to Bangalore, I think time will come, or rather time has already come, that we may always feel it much comfortable to go by Vande Bharat to Bangalore than going even by plane. Okay, said that, let's look into the science now. So what are biosimilars? If you have a new drug and if it is originating from a living source, it's called a biologic, and the product that has a complex structure similar to its efficacy is called biosimilar. For example, now because the context of my whole talk is going to be on glargine. But if it is going to be a synthetic, then we call that medication as a generic. We don't call it generic insulin. So I think the terminology is a matter of synonyms, but then you call it biosimilar when it comes from it's a biological product. So what is a physician's perspective on considering a biosimilar insulin? Most important is that we know that whether the indication is the same, but as a physician, I want to know whether there is a proof of efficacy, whether it is as good and safety. So efficacy and safety comes into it, and probably for a researcher, he'll be also looking at the evidence of bioequivalence, whether it is of the same potency, and also it will be looking at the, on a long-term vision, we are also going to be looking at the pharmacoeconomic impact as well as the immunogenicity testing. So the clinician perspective, that is, all of us have this question in mind. Now, if the price is going to be same, for example, you know that recently we had the GST, that some products have a very good change in the pricing, but not for the medical though. If the pricing is the same, why not switch to biosimilar? So this is a very valid question. Let's address it together with evidence and value. So if you are looking at an originator, innovator molecule that has been developed, you know that you have, starting from animal studies, then moving on, it will be mostly, it's a clinical driven studies, phase 1, phase 2, phase 3, and then it will be rolled out for its PKPD. So safety is being taken into consider. Then we talk about the drug development, drug dosage development. Then we have, so if you're looking at the originator development, it is going to be for safety, effectiveness with adequate and well controlled substantial evidence for a new product. Whereas in biosimilar development, it is probably an inverse of that same pyramid. So a lot of time is spent on the in vitro studies, because we have already the molecule. Now we are looking at whether it is of any kind of a bioequivalence, whether the potency is good, whether immunogenicity is good. So a lot of in vitro studies carry on, and last we'll do a little bit of clinical studies. So the amount, the time and amount spent on clinical studies are going to be in an inverse proportion compared to an originator development. So now comes the interchangeable biosimilars. What is this interchangeability, which is the gist of the topic of today? An interchangeability study shows how patients do when they switch back and forth between the reference product and the interchangeable biosimilar candidate. So we have a lot of reasons. For example, I will not say which institution, but there are all government institutions where, for example, I'll tell you, maybe I can quote CGHS. When the patient goes for a prescription on a monthly basis or once in 3 months, you can see the drugs that are given to the patient keeps changing, because what is available in the pharmacy is being given to the patient. So when you write injection glargine, for the first visit, he may get an insulin X. Then next month or next visit, that X may not be available, but glargine will be available in some other form, maybe a biosimilar. So patient, the doctor may tell that, okay, this is the same glargine that you have been taking, so continue the same. And you go to some pharmacy where they give advertisement of 60% price reduction. The same pharmacist also probably will tell the patient, if you want to save money, you can go for this particular insulin. So glargine will be there. So the patient feels that, okay, I'm taking the same product. So when there is going to be a change, will that affect my sugars? Will that affect my glycemic variability? Will that affect my HbA1c on a long term? So this is the question that has to come in each and every person's mind. So for a biosimilar to be considered to be interchangeable, it has 3 conditions to be met. A, it has to be an FDA approved biosimilar. B, it has to be it should produce the same clinical outcomes as the reference product in any given patient for any given indications. 3, if the biosimilar medication is given more than once to the same patient, either switching from the reference product or alternating with the reference product, it must produce the same efficacy. So if these 3 conditions are met, probably you can think that, okay, this is an interchangeable biosimilar. And we do have a design of studies which has to be done to call it biosimilar. So if you are looking at the regulatory approval pathway, you can see that between the originator and biosimilar as well as interchangeable biosimilar, one important step that a biosimilar interchangeable product has to go is the last one, which is now highlighted in orange, is a switch study. So it is just not that you compare it, but you also have to switch back and forth to see whether the patient has the same kind of glycemic efficacy during the crossover period. So if you are looking at the particular, so this how an interchangeable study design is concerned, so you can have this prototype of INSTRIDE 3 study, where a type 1 patients who completed INSTRIDE 1 study were on reference insulin glargine. 52 weeks, it was randomized into 1:1 basis. So here you can see the switching sequence. For the first 12 weeks, biosimilar insulin plus glargine. Then after 12 weeks, it was switched to reference insulin, glargine plus Lispro, then again back to biosimilar Lisprin and glargine, glargine and Lispro. And this is how the interchangeability study is being designed. So here you can see this, and this is the switch periods are also have the same time difference. And if you look at the interchangeable insulin, switching participants between the biosimilar glargine and the reference insulin glargine demonstrated equivalent efficacy. So if the efficacy is same, equivalent, then probably you can consider that particular insulin, glargine, which is being tested, is interchangeable. So, and looking at these safety data, you can see that hypoglycemia and immunogenicity. So, anytime hypoglycemia events were comparable, it should be comparable in both sequence throughout the study period. For example, if the reference product had 14.3, you can see this interchangeable biosimilar had 14.1%. So, switching participants between the biosimilar glargine and reference insulin glargine demonstrated similar safety and immunogenicity, showing the patient taking the reference insulin and glargine can safely switch to biosimilar glargine. Because we had a lot of issues regarding glargine almost 78 decades back because of the risk of cancer and glargine, because based upon the insurance data studied in Scandinavian countries, it has all been found to be fallacious. So now when you have a new insulin or a biosimilar insulin, these questions may creep up in your mind. Hence the immunogenicity data is very important. So I think we have a lot of studies. Because of want of time, I shall not go too much into it. But if you can look at the INSTIGHT 3, which is the interchangeable study, you have just as alluded to, you could see that switching the participants between the interchangeable and reference insulin demonstrated equivalent efficacy and safety and immunogenicity. So, adoption of interchangeable biosimilar insulin in India, what Indian physicians have to say. This is again article written by esteemed endocrinologist Prasanna Kumar from Bangalore and his team. So, barriers of prescription, according to them, or the interchangeable biosimilar insulin was that from the physician's perspective is clear and detailed communication regarding the benefits and the safety of the interchangeable biosimilar insulins to address the patient concerns and misconceptions were not properly addressed. Patient education was not proper. A slight reduction in the price of the biosimilar insulin glargine can facilitate large number of patients, of new patients. Probably it can, question is whether it is going to help in adherence or not. Pharmaceutical companies can extend their reach to rural areas, thereby contributing a wider adoption of biosimilar insulin glargine. And what was the experts' perspective on barriers of prescribing interchangeable? We have a lot. I think for want of time, I cannot talk too much on it. Just to make sure that whatever may be the insulin, the cold chain has to be there. So even if you're talking about a bioequivalence product, but if it does not reach the patient's hand with the appropriate cold chain, whatever been the discussion here probably may not give the kind of effect that we want to. So interchangeable biosimilar insulin will help to improve the accessibility of insulin, a life-saving medicine in India. I think probably around 3 years back, I think even in American Diabetic Association, a lot of discussion were happening on insulin on large-scale availability. India, since we don't come under any kind of an government-sponsored program for accessing the medications, I think a good analog insulin, if it is available at a cheaper rate, which is as efficacious as its innovator, probably can will give a lot of benefits to the patients, especially in preventing the target organ damages. So it is not the question of glycemic control. It is also diabetes. How are we going to tard off the various complications of diabetes, of probably inefficient glycemic control. So availability of the product, it is reaching into all the tiers. So interchangeability is more just than the similarity. So even with the same price, you can prescribe with more confidence, freedom to switch, and you have the reduced future cost pressure, as well as you can have backup for the shortage of innovator, because innovator probably the raw material has to come from abroad, but when you have a biosimilar, it is probably make in India. So my dear colleagues, to summarize and conclude, interchangeable biosimilar insulin glargine is an additional clinical evidence for evaluation of safety in switching from reference product, a safe option for switch from reference insulin glargine product, an effective solution for affordable and accessible insulin in India. The same clinical outcomes proven switching efficacy, equal price, and greater flexibility. This is what Dr. Prasanna Kumar had written in the last and in his editorial column. And it offers greater flexibility and future access. Thank you for your patient listening.
Thank you, sir. So next online we have Dr. Arun Raghavan speaking on remission in diabetes. How, whom, and how long?
Right, thank you for the introduction. I would also like to thank the organizers of DAISICON for having me here, and my greetings to all the seniors and my teachers in the audience, as well as my friends. So, my first disclosure is no pharmaceutical company is obviously going to fund my talk. My talk is on remission of diabetes. This has been probably a new buzz that we've all been looking around, hearing about in the last few years, right? It is not uncommon that our patients come to us, talk to us about the possibility of remission, right? So I'm going to break it down for you. We're going to understand in whom we can actually look at remission and whether remission is sustainable, right? These are what we are going to look at in my discussion today, right? So remission in diabetes, how, whom, and how long. So over the years, what we have learned is that diabetes is a progressive disorder, right? When I was in medical school, what I was taught is keep your HbA1c under control. That's the only thing that we can look at to prevent patients from micro and macrovascular complications. All the landmark glucose lowering trials, including the UKPDS, taught us that HbA1c reference range was 7, keep it under control, there's no other choice, diabetes will progress with time. Right? Now, I don't know how much of that is applicable in today's context. Now, think about this. If you have a patient whose HbA1c is about 7.5 with SGLT2 inhibitors and GLP-1 receptor agonist, perhaps is likely to do better than a patient who has a HbA1c of 7 with sulfonylureas and insulin, isn't it? So that's how the paradigm, as well as our understanding, our approach to diabetes is changing. So the dogma of irreversibility, that diabetes is actually irreversible, is actually shattered. Diabetes is indeed reversible. The caveat is in whom. That is the point that we have to actually look at. Now, of course, there are a lot of new age health tech companies that they are actually having a commercial angle to it. They've made it a blanket rule, right? As if diabetes is reversible for all patients. No, that is indeed not possible. Now, how do we need to approach this? We need to understand in which set of patients there is maximum chances of remission, right? So the guidelines have evolved. Now, the current guidelines, which came about 4 years, made the definition far more simplified. Now, what is remission? A patient whose HbA1c is less than 6.5 without any medication over 3 months is considered to be in remission. Not reversal, not cure, but remission. Why not reversal? Because reversal can mean reversal of complications or reversal from insulin, so on and so forth. Why not cure? Because cure can be actually misleading. It might give a false sense of hope to the patient that diabetes is out of the window, that they need not even monitor their blood glucose levels, right? That's not the case. Patients who are under remission have to be more vigilant. They need to not only monitor their glycemic variability, whether they need to resume medicines or not. Even the pre-diabetes zone is implicated with macro and microvascular complications. So that is why the term remission and not reversal or cure. So there is a consensus across the global bodies that the HbA1c less than 6.5, as I said, without any medicines, are considered that they are in remission. So whom do we actually look at? Who are the potential candidates where we can look at remission? Of course, there are some naturally remitting forms of diabetes, which are stress-induced hyperglycemia, patients who may have post-surgical CABG, burns, or corticosteroid-induced gestational diabetes, where there is transient hyperglycemia, and after that you see remission. And then types of diabetes where there is no remission possible, of course, type 1 diabetes, pancreatic diabetes, and MODY. Where there is a possibility of remission is type 2 diabetes and other endocrine disorders such as Cushing's, acromegaly, thyrotoxicosis. We are not going to venture into that endocrine disorders. Our focus today is going to be on type 2 diabetes. That is indeed the elephant in the room. Now, what are the predictors of type 2 diabetes in terms of remission? Now, any patient's journey with type 2 diabetes is quite long, right? Particularly in the Indian context, we see patients getting diagnosed as early as even 20s and 30s, right? So the exposure of diabetes is also going to be quite long, starting from diagnosis, starting metformin, escalation of therapy, then macrovascular complications, the entire journey, right? So where do we actually intervene? Which is the best opportunity, which is the best window period to actually make a difference in terms of remission? Now, this is a beautiful illustration which shows that this is probably the best. Is it working? I don't think it's working. Okay, this is the best window period from all the data that we have. Within the first 6 years of onset of diabetes is the best window period where we can look at remission. I'm going to show you that data in the subsequent slides. What are the current approaches? Surgical interventions, bariatric surgeries have been there since 1990s. There's a wealth of data of remission. And then we have pharmacological interventions, even using insulin very early in type 2 diabetes. Within 2 years, if used in basal bolus, intensive insulin therapy has resulted in remissions. And then now we have the next generation GLP-1 receptor agonists, which have such robust weight reduction, also can result in remission. And then we have behavioral interventions, which we are going to look at in the subsequent slides. And then the digital technology interventions, such as the twin model that we have, Vorta in the US, they leverage technology to track disease progression very closely. So by using technology, they are actually monitoring very dynamically. So they are able to enable patients even better to adhere to better diet and lifestyle. Now, this is probably the first data that we had, which showed that probably remission is possible in patients who are actually losing weight. Now, look ahead trial explored how much metabolic improvement can be there in patients who adhere to a good nutrition lifestyle having weight reduction. Now, patients' mean HbA1c in the trial was about 7.3. The mean duration of diabetes in the look ahead trial was about 5 years. In over 5,000 patients, multi-centric trial in over 5,000 patients, 5 years was the mean HbA1c duration, 7.3, 5 years was the duration, 7.3 is the mean HbA1c. Diabetes remission was about 11.5% in patients who achieved weight reduction of about 8.6%. So this was the first trial which gave us the assurance, promise, paved way for future trials to explore the possibility of remission with weight reduction, right? And then came the DIRECT trial, which is the landmark trial for diabetes remission. The reason why we are even talking about remission today is because of this very trial. DIRECT trial was, I'm going to show you the data, was by Roy Taylor. This was in patients duration less than 6 years between the age of 20 and 65, having a BMI of 29 to 45. The mean BMI was about 34. The duration of the trial was first 1 year. Patients had a very, very low calorie diet, only about 800 calories. And then there was stepped food reintroduction in about 2 to 8 weeks. At the end of 1 year, there was about 10 kg weight reduction, and 47% patients actually had remission in 12 months. So first year, about half the patients in the intervention arm had remission of type 2 diabetes. The second year, there was no active intervention. It was only a follow-up to see whether patients' reduction in body weight was sustained and remission was also sustained. When you look at second year, there was about still 36% patients who were still under remission. So this was the landmark trial which demonstrated that weight reduction can actually help patients reverse type 2 diabetes. The most important factor was, of course, weight loss. The other interesting takeaway from the study is 86% of participants who lost 15 kgs achieved remission. 86%. So if you have the best odds is catch someone who's less than 5-6 years of diabetes, who will have reasonably good beta cell reserve, of course, right? So whose HbA1c is less than 7.5. Then in those patients, when you achieve 15 kgs body weight, the chances of remission is almost 100%. So that is what the data actually tells you. So after the DIRECT study, we have the DIADEM study, which included patients from Africa. And then we also have the DIRECT study from Australia, DIRECT Australia study, DIAREM study from India, all of them with the similar approaches of calorie deficit, which showed very similar data. 61% in the diadem study in Africa, 61% of remission within 1 year. So all of them showing calorie restriction is probably the best foot forward. The twin cycle hypothesis, Roy Taylor came up with this. Why does it actually result in remission? Is because when there is lipid accumulation in the liver, what happens is there is insulin resistance, right? So there's a change in the liver dynamics, energy dynamics. There is further glucose production, then there is lipogenesis, and then the fatty acids are released. Then there is also increase in the pancreatic lipid accumulation, right? And when there is MAFLD, there is also release of hepatokines, the inflammatory cytokines, which is also going to impair insulin sensitivity. All this is going to result in functional injury of the beta cell, worsening the beta cell. Whereas, on the contrary, when you actually result in body fat reduction, when there is a reduction of liver fat, what happens? The insulin resistance comes down, insulin sensitivity gets better, and also beta cell function improves. So that is why we kind of see remission. So pretty straightforward. Reduce patient's calorie, gets the job done, gets the weight under control, and then there is a scope of reversal. Two kinds of diets are there: low energy diets as well as low carbohydrate diets, which we are all very fond of. Let's see which has which edges over the other. Low calorie diets are anywhere between 1,200 to 1,500. Very low calorie diets is about 400 to 800, which we saw in the direct study. I don't know how much it is sustainable, but that's what very low calorie diet is. Low carbohydrate diet is between 10 to 26%. Very low carbohydrate diet is less than 10%. Again, we don't know how sustainable is very low carbohydrate diet. So which is better, low carbohydrate diet or low calorie diet? We are going to look at that. Both of them have shown improvement in the cardiovascular risk indices, both low carbohydrate diet as well as low calorie diet. However, the RCT for weight reduction is better with low calorie diet compared to low carbohydrate diet, because there is RCT evidence for up to even 2 years with low calorie diet. And low calorie diet, as we've seen in direct trial, has demonstrated 46% remission at 12 months compared to only about 11% remission with low calorie diet. Perhaps the way to go is low calorie diet rather than low carbohydrate diet. So the published meta-analysis so far shows you that hypocaloric diet is what matters, does not support any particular macronutrient, be it protein, fat, doesn't matter. What the main essence is, the calorie deficit should be there, right? That's the main key takeaway from this. Now, going to the next part of my talk is bariatric surgery has been there in the reckoning from 1990s, right? We know that bariatric surgery is probably the most powerful tool which results in remission, wealth of evidence, so I'm not going to go much into it. 76% remission at 2 years, about 70% in 5 years, 70% remission in 5 years. Other factors is, again, duration of diabetes, beta cell reserve. If patients on multiple doses of insulin, becomes more complex, right? Whereas patients' HbA1c is okay, less number of OADs becomes more easier. So background A1C, all those factors matter. Look at 10 years data, 47% patients still under remission, right? That is how powerful bariatric surgery is with regards to remission. So bariatric surgery compared with lifestyle intervention as well as pharmacological intervention, bariatric surgery seems to score over, right? That's the data that we have so far. Early intensive insulin therapy, there have been multiple studies demonstrating, even insulin pump, multiple daily insulins, studies looking at detamir as well as aspart, multiple daily doses. At about 2 to 4 weeks, within 2 years of diabetes, has helped patients to reverse diabetes. However, in the last 6 years, there's not been any new study. There was only one study. This is probably because long-term data may not be favorable, because there will be weight gain, hypoglycemia, so on and so forth. So not much of data. Why there is improvement is because there is improvement in the glucagon levels, improvement in the beta cell function, rest to the beta cell itself. We've seen that from also the origin trial, right? So that's why there seems to be improvement and helping patients reverse. So the final narrative over here, if you look at the blue and red dotted graph, that's the sleeve and bypass, gets patient to reverse diabetes from a baseline HbA1c of 10, 9, double-digit figures, bariatric surgeries, right? And we've seen sustainable remission even up to 10 years. Whereas other low-calorie diets, the HbA1c, as we've seen from the data, was 7.5, 7.3, 7.5, but still there is 2 to 3 years of promising data. So far, compared to bariatric surgery, we do not have that much of data. Bariatric surgery is still the most powerful tool. However, low-calorie diets have proven, they have shown enough promise, but there should be further trials, further data to see how many years it can be actually sustainable. Then final word on GLP-1s. As I said, the next generation GLP-1s are here. The third generation GLP-1 analogs, if you look at the Rita-2 tried or the Servo-2 tried, the triple GLP-1 agonists are actually resulting in 30 to 35% body weight reduction. Almost they are, brushing upon the bariatric surgery level of weight reduction, right? The next generation GLP-1 receptor agonist. Now, we've looked at scale, step 1, step 2, surmount. All of these studies showed patients with pre-diabetes, they reversed to normal glycemia, patients with diabetes reversed. But the only caveat over here is patients continue to take the drugs in all of these studies, right? So they are not purely dedicated remission studies. So further data is required. Also, once you withdraw the GLP-1, how much of rebound weight is going to happen? All those are factors that we need to deliberate and discuss and see what the trial has in store. So finally, I think this is my last trial, or one before that. Okay, how do we approach baseline HbA1c? Is extremely important. Patients who have a HbA1c lower than 7.5 are potential candidates. When patients' body weight, BMI is higher, there is an opportunity for us to achieve weight reduction with calorie deficit. And then the duration of diabetes less than 6 years, as demonstrated by direct trial as well as the look-ahead trial. All these are the factors to consider in patients who are likely to reverse. So this is the National Health Program of UK, which was rolled out last year. There was about 2,500 patients in a large-scale setting. 32% patients achieved remission. Why UK? Because direct study is from UK. And now the impact, there's been an impetus. 25,000 patients have been enrolled, and they are likely to expand it to 50,000 patients in the coming years. That's the large-scale impact that the direct study has had. Very promising data so far, but let's see what happens in the next few years. So finally, to conclude my talk, remission is something that we can consider in patients, especially in the early stage, new onset type 2 diabetes within 5 to 6 years, particularly in patients who are having higher BMI. It shouldn't be a blanket rule for all patients. And most importantly, it should be patients who are highly motivated. And another important factor is we should tell patients that possibly the remission can be for 1 year or 2 years, but even those 2 years of remission is still valuable in the long run. With this, I'd like to conclude my talk. Thank you.
Reducing the carbohydrate reversal is better. Suppose instead of continuing the same diet pattern, whatever you are taking, increase the expenditure by exercise, aerobic exercise. Instead of 30 minutes, you make it to 1 hour. Will it produce the same result?
All the studies have not shown exercise to benefit that much of weight reduction and improvement in the beta cell.
Not for
There
weight
are
reduction.
studies.
Not for weight reduction. This is for insulin resistance. Because the endothelial dysfunction is a primary factor everywhere. So that is dominantly by the insulin resistance.
Yeah, there were a couple of trials, in fact, which looked at holistic weight reduction with nutrition as well as exercise. Those studies actually did not demonstrate this much of weight reduction. The calorie deficit less than 800 is what had weight reduction of about 15 kgs and consequent improvement or remission. The holistic approach, couple of studies did not show that much of impact. That's what the studies had to say.
Yeah, because what I felt was, because the insulin resistance addressed to primarily by the exercise.
Absolutely. I mean, if you, in fact, include even strength training, you're going to increase the insulin receptors even in the muscle, because muscle tissue is also going to expand. Adipose tissue is going to come down. So adipose tissue sensitivity to insulin is also going to get better. Theoretically, sounds perfect. But the data that we have is only this.
Thank you. Thank you.
Sir, in hypertension, sir, One of the drugs which will prevent reducing the blood pressure is ginseng, sir. Because we see a lot of prescriptions with the multivitamins associated with ginseng in the composition of the multivitamins or B complex with ginseng. So ginseng is one compound which will not have an effect in reducing the blood pressure, whatever drugs you give. So there is a lot of evidence also in it, sir. So that also we have to take into recognition.
Thank you for the input, sir. I'm not aware of it.
No, sir. Because
Okay,
just
okay,
I want
sir,
and injection Bradostat, one shot will give you protection for 6 months.
Yes, sir.
So I think so in the next generation, I think so that will be in the pipeline, sir.
Sure, sir.
Sir, regarding the bariatric surgery, I want to know, because you talked about Roux-en-Y, sleeve gastrectomy, balloon, everything is there.
I'm not a surgeon, but yeah, I'll
But
answer.
whatever
as
it is,
much-
I also not a surgeon, sir.
Go
But
for it.
one thing is, what is the rebound weight gain after a long period of time, sir? Because
Yeah.
there are some studies to show
Yeah.
there is a weight regain.
Absolutely. I mean, weight regain happens after 2 years. There is data to show after 5 years. And that's why now we are having GLP-1 use even after bariatric surgery to actually mitigate that rebound weight gain. Weight gain does happen. There's no doubt about it. Yeah.
That is what now you are practicing, sir.
That is why, yes, of course, GLP-1 receptor agonists are globally being used after bariatric surgery. But then behavioral reinforcement, reiteration, I think should happen. Finally, that is also something which we cannot underestimate or undermine in any patient. I think that's also something that we need to constantly reiterate to our patients.
Even after remission of diabetes, the patient should have some civic sense, sir. Not eat hedonic eating, and he should not keep going on snacking, binge eating. These are things which are going to add to the benefit of the patient in the long run, sir.
The patient was so sensible, they may not even have diabetes, but that's how it is. Yeah.
Thank you so much for the opportunity.